Very good morning to one and all present here. Imagine you walk into an emergency room or a medical ward. The monitors are buzzing, the team is rushed, and right there in front of you is a critical patient. Before you order a single expensive blood test, before you wheel them away to a multi-million-dollar CT scanner, what is the very first thing you do? You reach out your hand and touch the wrist. With that single simple human connection, you are plugging your mind directly into their cardiovascular system. The pulse is not just a collection of numbers on a chart, it's a detailed story written by the left ventricle and told through the arterial valves. Today we are going to learn how to read the story like expert clinicians. Welcome to Pulse Examination, a bedside clinical approach. So now let's break it down. So let's start with the official definition. A pulse is a pressure distension wave which is produced by the contraction of the left ventricles against a partially filled aorta, which is then transmitted to the peripheries and is felt on a peripheral artery against a hard bony prominence. Think of it like dropping a pebble into a still pond. The ripples that travel outward are the pressure wave. In our body, the pebble is the contraction of the left ventricle forcing blood into a partially filled aorta. This creates a wave transmitted right down to the peripheries, which we can feel by pinning a peripheral artery up against a hard bony prominence. If there is no bone behind that artery, you can't trap it and you won't feel it. When we assess an arterial pulse, we need a systematic checklist, so we don't miss anything. We look at rate, rhythm, volume, character, radioradial or radiofemoral delay, whether all the peripheral pulses are felt, and the condition of the vessel wall. So now, how do we actually document a pulse properly? Here is an example of a perfect clinical note. 72 beats per minute, regular rhythm, normal volume and character, all peripheral pulses are well felt, no radioradial or radiofemoral delay, no vessel wall thickening. Make this your default mental template. So how do we actually feel the pulse? We use the 3-finger method along the radius bone. Here is a tip to remember what each finger does. First, the distal finger, which acts like a shield. It prevents backflow or retrograde pulsations from the palmar arch from confusing you. Second, the proximal finger is your stabilizer. It holds the artery steady against the bone. Third, the middle finger is your detective. It does the actual filling and counting. Now, everyone put your fingers on your own radial artery and feel those components working together. Now let's look at the first characteristic, that is your pulse rate. To calculate it accurately at the bedside, locate the radial artery and count the beats for 1 full minute using a wristwatch with a second hand. Don't shortcut it by counting for only 15 seconds and then multiplying it by 4 because you will completely miss subtle rhythm changes or an irregular pulse. A normal resting heart rate is 60 to 100 beats per minute. If it climbs over 100, we call it tachycardia. If it drops below 60, it's bradycardia. Let's look at the clinical causes of tachycardia first. Physical reasons are normal. Think of crying infants, exercise, high altitude, or the anxiety you feel right before a major exam. Pathological causes mean something is wrong, like tachyarrhythmias or high output states like severe anemia or thyrotoxicosis, where the body demands massive blood flow. And don't forget drugs like atropine, nicotine, and caffeine. For bradycardia, physiologically we see it in our well-conditioned athletes or when we are deeply asleep. Pathologically, it warns us of severe hypoxia, hypothyroidism, obstructive jaundice, or raised intracranial pressure, which you will know as the classic Cushing's reflex. Finally, drugs like beta blockers, verapamil, and digoxin will purposely pull the rate down. If a patient presents with a slow heart rate, always open their charts and look at their medication list first. Here is a high-yield clinical pearl that you will use every single day on the medical wards. There is a strict mathematical relationship between pulse and temperature, known as Liebermeister's rule. The rule states that for every 1 degree rise in body temperature, the pulse rate should increase by roughly 10 beats per minute. It's like the body's built-in thermostat and engine working together. But medicine gets interesting when this rule breaks. If a patient has a fever, but their pulse rate is significantly higher than expected for that degree of temperature rise, they have relative tachycardia. This points you directly towards conditions like acute rheumatic carditis, diphtheric myocarditis, or tuberculosis. Conversely, if they have a screaming hot fever but their pulse remains slow and flat, that is relative bradycardia. The pulse is lower than expected. This is a massive clinical sign. It is classic for conditions like typhoid, the first week of enteric fever, dengue fever, leptospirosis, or yellow fever. In yellow fever, it is known as Paget's sign. Non-infectious causes include patients already taking beta blockers or those experiencing a drug fever. So remember, when you look at a vitals chart, never look at temperature and pulse in isolation. Always cross-reference them. Now let's move on to rhythm. A normal pulse rhythm is regular, ticking away like a metronome. But when it gets irregular, we break it down into 3 distinct clinical flavors. Regularly irregular. There is a method to the madness. The pulse is irregular, but it repeats a predictable pattern. Think of ventricular bigeminy or trigeminy, or sinus arrhythmia, where the heart rate speeds up when you breathe in and slows down when you breathe out. Next, you have irregularly irregular. It is complete, unmitigated chaos. There is absolutely no repeating pattern or rhyme to the beats. When you feel this, your mind should immediately scream atrial fibrillation. It can also be caused by frequent ventricular ectopics. Next, you have regular with occasional irregularity. A normal rhythm that is occasionally interrupted by a sudden premature skip, like an extrasystole. Now look at the right side of the slide. This is a common trap for medical students. Can an arrhythmia present with a perfectly regular rhythm? Absolutely. Atrial flutter with a fixed block, ventricular tachycardia, and first or second degree heart blocks can feel completely regular to your fingers. This is why the slide emphasizes our key bedside takeaway. Always correlate your pulse rhythm findings with the patient's history, clinical signs, and most importantly, a 12-lead ECG for an accurate diagnosis. What happens when the heart is contracting so fast or so erratically that some of the beats are too weak to push a wave all the way to the wrist? That's where we calculate the apex pulse deficit. By definition, it is the difference between the actual heart rate, which is counted by listening directly to the heart with a stethoscope at the apex, and the peripheral pulse rate, which is counted at the radial artery. To do this correctly, 2 individuals must count simultaneously for 1 full minute using the same clock. One listens to the chest, the other feels the wrist. A clinical tip here: what if you are working the night shift alone and don't have a second person? The key point here is that you can simultaneously place your stethoscope over the apex with one hand and feel the radial pulse with your other hand. You won't be able to count both at once, but you will instantly feel if a heartbeat you hear in your ear fails to produce a mechanical pulse in your fingers. This tells you that some cardiac contractions are hemodynamically ineffective, wasted energy via failing heart. Now let's put the apex pulse deficit to work right away. If you feel an irregular pulse at the bedside, your two top differentials are usually atrial fibrillation and ventricular premature complexes. How do we differentiate them using just our hands, eyes, and ears? First, look at the apex pulse deficit. In atrial fibrillation, because the atria are just quivering chaotically, the deficit is usually quite wide, greater than 10 beats per minute. In ventricular premature contractions, it is usually narrow, less than 10 beats per minute. Next, look at the neck veins, JVP A wave. In atrial fibrillation, because there is no coordinated atrial contraction, the A wave is completely absent. In ventricular premature contractions, it remains normal. Listen to the first heart sound. In atrial fibrillation, because the filling time changes drastically with every single beat, S1 has a highly variable intensity, sometimes loud, sometimes soft. In ventricular premature contractions, it is typically normal. Now here is a brilliant bedside trick, the effect of exercise or a firm hand grip. If you make the patient squeeze your fingers or do a quick bed exercise to raise their heart rate, an atrial fibrillation irregularity will persist. It just gets faster and more chaotic. But if it's ventricular premature complexes, the pulse will often become regular because the sinus node speeds up and overrides those ectopic premature beats. Memorize this table, it is a pure gold for ward rounds. Now let's transition to pulse volume. What exactly are your fingers feeling when you assess volume? Simply put, pulse volume is a direct bedside measure of the patient's pulse pressure. And what is pulse pressure? It is the mathematical difference between the systolic and diastolic blood pressure. A normal pulse pressure is between 30 and 60 mm mercury. If the difference is greater than 60 mm mercury, we call it high volume or hyperkinetic pulse. Think of cardiac structural causes where blood leaks backward or escapes rapidly, like aortic regurgitation, severe mitral regurgitation, patent ductus arteriosus, or a complete heart block, where the heart beats slowly but ejects a massive volume every time. Physiologically, you will see a high volume pulse during fever, pregnancy, or after heavy exercise. Pathologically, high output states like severe anemia or thyrotoxicosis drive this up. On the flip side, if the pulse pressure drops below 30 mm mercury, it is a low volume or hypokinetic pulse. This happens when the pump is failing or empty, like congestive cardiac failure, severe hypovolemia like dehydration or blood loss, shock or constrictive pericarditis, where the heart is literally strangled and cannot fill properly. When you feel a weak, thready pulse, your patient is telling you their stroke volume is dangerously low. So now, when you communicate with other medical staff, you can't just say the pulse feels a bit weak or it feels kind of strong. We must use a standardized clinical language. We use a clinical scale from 0 to 4 to grade arterial pulses. So grade 0 is the complete absence of pulsation. You feel absolutely nothing, a flat line under your fingers. This is a medical emergency indicating ischemia or occlusion. Grade 1, small, feeble or reduced pulsation. It is a thready, barely palpable wave that easily disappears if you press even slightly too hard. Grade 2, palpable but diminished compared to the other side. Grade 3, this is our target, a normal healthy pulsation. Grade 4 is a large, booming, high volume or bounding pulsation. Here is a pro tip. Where is the best place to assess the true character and grade of a pulse? The answer is the carotid arteries. Now you may ask why. Because they are closest to the central aortic arch and give the truest reflection of the central hemodynamics. There are two major exceptions to this rule: a collapsing pulse and pulsus bisferiens, both of which are actually appreciated better peripherally at the radial or brachial arteries. Let's look at exactly how we evaluate those unique shapes next. Now we are entering advanced clinical territory, character of the pulse. To truly appreciate the character, we use what is called the trisection method. This means you apply varying degrees of light pressure with your finger pads to divide the arterial pulse wave into three distinct components: the upstroke or the ascending limb, the systolic peak or the crest, and the diastolic slope or the descending limb. Let's break down what a normal pulse wave, the catacrotic pulse, looks like under microscopic level palpation. First, there is a rapid rise called the percussion wave. This is caused by the sudden arrival of the pressure wave generated by the left ventricular ejection. Next is a smaller peak called the tidal wave, which is simply the pressure wave reflecting back from the upper parts of the body. Then the pressure drops, creating a sharp dip called the dicrotic notch or the incisura, which marks the exact moment the aortic and the pulmonary valves snap shut. Finally, we see the dicrotic wave, which is the rebound wave bouncing off the closed valves down to the lower body. By feeling for these microscopic components using the trisection method, you can catch cardiac structural anomalies early, guiding crucial clinical decisions before an echocardiogram is even ordered. Here is a fascinating physics question that often trips up medical students in oral exams. Is the speed of the pulse wave the same as the speed of actual blood flow? The answer is an absolute no. The speed of the pulse wave is about 5 meters per second, whereas the actual fluid velocity of blood flow is a sluggish 0.5 meters per second. Think of it like a row of standing dominoes. If you push the first domino, the wave of falling dominoes travels down the line instantly, even though each individual domino only moves a couple of inches. The pressure wave travels 10 times faster than the physical red blood cells. Because of this, the farther away an artery is from the heart, the longer it takes for that pressure wave to arrive. It takes about 30 milliseconds to hit the carotid, 60 milliseconds to reach the brachial, 75 milliseconds to reach the femoral, and 80 milliseconds to register at the radial artery at the wrist. Notice something crucial here. Normally, the radial pulse is felt 5 to 10 milliseconds later than the femoral pulse. If it takes any longer, you have a delay, which is a massive clinical red flag for conditions like coarctation of aorta. Now we are diving into the clinical evaluation of the arterial pulse waveforms. It is a vital clinical scale in bedside cardiovascular examination. Before we look at the abnormal patterns, let's look at the fundamental physiological principle which we have already studied. The pulse wave travels significantly faster than the actual blood flow. While blood flows at a relative low velocity of roughly 0.5 meters per second, the kinetic pressure wave propagates through the arterial wall at about 5 meters per second. Now look at waveform 1, the normal pulse. In a healthy individual, you will see a sharp, smooth upstroke during cardiac systole, reaching a single peak, followed by a gradual downstroke during diastole. When the aortic valve is narrowed or stenosed, it alters this shape dramatically. Waveform 2 is a slow rising pulse, where the blood takes longer to eject. This is closely related to waveform 3, pulsus parvus et tardus, with an anacrotic pulse. Parvus means small volume and tardus means late or slow rising. You will notice a distinct notch on the upstroke called the anacrotic notch, followed by a delayed flattened peak. This is a classic hallmark of severe aortic stenosis. Conversely, if we look down at the waveform 6, the collapsing pulse, also known as the water hammer pulse, we see the exact opposite. It features a massive, sharp upstroke but lacks sustained volume, dropping off precipitously. It indicates a high stroke volume leaving the heart but instantly leaking backward or sideways. Next, let's examine pulses with multiple peaks. Waveform 4 is pulsus bispherians. Here, you see two systolic peaks, S1 and A1. This is frequently felt in combined aortic stenosis and aortic regurgitation. Do not confuse this with waveform 5, the diacrotic pulse. While it also has two peaks, the second peak occurs after the closure of the aortic valve, A2, during diastole. It features a highly prominent diacrotic notch, often seen in conditions with low cardiac output and high systemic vascular resistance. Next, waveform 7 is the spike and dome pulse. This unique waveform features a sharp systolic spike followed by a broader lower dome. This pattern is highly characteristic of HOCM, which is hypertrophic obstructive cardiomyopathy. Finally, waveform 8 shows pulsus bigeminus. This is an alternating rhythm where a strong normal beat is regularly followed by a premature weaker ectopic beat followed by a pause. Okay, now let's look at the absolute king of bedside physical science, the collapsing pulse, also known as the water hammer or the Watson's pulse. It is characterized by a violently rapid upstroke followed by an immediate sudden collapse of the wave because of low systemic vascular resistance. So how do we elicit it at the bedside? Follow these 6 steps carefully. First, palpate the patient's radial artery and trace it proximally. Then wrap the flat palms of your fingers firmly around the front of the patient's forearm. Third, palpate the radial and the ulnar arteries together by encircling the wrist. Fourth, abruptly raise the patient's hand completely above their shoulder, keeping their arm straight and in line with the heart. As you raise the arm, you will feel an abrupt, knocking thrust under your metacarpal heads followed by an immediate empty collapse. The sensation feels exactly like tilting an old-fashioned water hammer toy. So, why does this happen? The rapid upstroke is due to a massive stroke volume bursting out of the left ventricle. The rapid collapse happens because during diastole, the blood immediately rushes backward into the left ventricle, which is like a diastolic runoff combined with reflex vasodilation. This is the hallmark sign of aortic regurgitation, patent ductus arteriosus, or hypokinetic states like severe anemia, pregnancy, and thyrotoxicosis. Now let's look at a fascinating waveform where you will actually feel 2 distinct beats within a single cardiac cycle. We have 2 examples here, pulsus bispherians and pulsus diacroticus. We are starting with pulsus bispherians. In Latin, bispherians literally means twice beating. The most critical thing to remember here is the timing. Both peaks happen during systole. When you palpate the brachial or radial artery, you will feel a rapid upstroke. This is the percussion wave, followed by a quick dip and then a second slower rising tidal wave. So how do you find pulsus bispherians? Use light pressure to occlude the artery and then release it very slowly. If you feel the double hit during the contraction phase, it's a classic indicator of combined aortic stenosis and aortic regurgitation, or HOCM. The heart is essentially ejecting blood in 2 distinct shafts during a single beat. Students constantly mix the previous slide up with this one, pulsus dichroticus. While both involve feeling two beats, the math of the cycle is completely different. Unlike Bispherians, here you feel one peak in systole and the second peak in diastole. What you are actually feeling is a massive exaggeration of the normal dichrotic wave, the rebound of blood against the closed aortic valve. This happens when a patient has a very low cardiac output combined with low diastolic pressure. You will see this in the ICU or ER in severe cases of dehydration, septic shock, or advanced heart failure. So here is your rule for the boards. Bispherians, double peak in systole, dichrotic, one in systole, one in diastole. One is an outflow problem, the other is a low pressure, low output problem. Keep them separate and you will master the arterial exam. Our final pair of waveforms involves alternating volumes. First we have the pulsus alternans. This is characterized by a perfectly regular rhythm, but the pulse alternates between a high volume wave and a low volume wave. This is a severe peripheral manifestation of the left ventricular failure. The heart is struggling so bad that every second beat is mechanically weak. Second, we have the pulsus bigeminus. This looks similar but has an irregular rhythm. It is a normal beat followed quickly by a premature, weak ectopic beat and have a compensatory pause. This is a classic sign of digoxin toxicity or underlying arrhythmias. So how do we catch pulsus alternans at the bedside if it's too subtle for our fingers? Yes, we use a blood pressure cuff. First, position the patient semi-recumbent, then inflate the cuff to at least 20 mm mercury above their systolic pressure. Then deflate the cuff very slowly as you pass the systolic threshold. Listen closely through your stethoscope. Initially, you will hear only the Korotkov sounds of the stronger high-volume pulses. As you drop the pressure further, the rate of the sounds will suddenly double because the weaker low-volume pulses finally break through. This doubling of Korotkov sounds confirms left ventricular distress. Now let's tackle one of the most famous and frequently misunderstood concepts in clinical cardiology, pulsus paradoxus. Let's get the definition crystal clear first. Pulsus paradoxus is defined as an exaggerated decrease in systolic blood pressure by more than 10 mm Hg during normal inspiration. So why do I say exaggerated? Because normally when you take a breath in, your systolic pressure drops slightly but by less than 10 mm mercury. This happens because inspiration drops intrathoracic pressure, pulling more blood into the right side of the heart, which causes the interventricular septum to bulge slightly into the left ventricle, which reduces its stroke volume. And that's your normal physiology. But in certain pathologies, this effect goes into overdrive. The paradox isn't that the pulse does something impossible. The paradox is that while you hear the heart beating normally through your stethoscope, the peripheral pulse at the rest dramatically weakens or completely vanishes during inspiration. So when should you look for this? Write this down. Cardiac tamponade, where the fluid in the pericardium literally strangles the heart, constrictive pericarditis, severe acute asthma, and COPD. If a patient with severe asthma shows pulsus paradoxus, it warns you that they are heading towards respiratory failure. Let's look under the hood to see the exact mechanism. Imagine the heart is inside a rigid annealing box. This happens when the pericardium is full of fluid under high pressure, like in cardiac tamponade. During inspiration, negative intrathoracic pressure draws a massive rush of venous blood into the right atrium and right ventricle. Because the right ventricle is expanding, but trapped inside this tight fluid box, it cannot expand outward. It has only one choice. It must expand inward. pushing the interventricular septum to the left. This sudden septal shift compresses the left ventricle, severely reducing its filling capacity, that is the end diastolic volume. Less blood in the left ventricle means less blood ejected during systole. So the stroke volume drops, which causes that sharp drop in systolic blood pressure, which is more than 10 mm mercury. Think of it as a spatial tug of war inside a crowded room. When the right side takes up more space, the left side gets crushed. Our final pair of waveforms involves alternating volumes. First, we have the pulsus alternans. This is characterized by a perfectly regular rhythm, but the pulse alternates between a high volume wave and a low volume wave. This is a severe peripheral manifestation of the left ventricular failure. The heart is struggling so bad that every second beat is mechanically weak. Second, we have the pulsus bigeminus. This looks similar but has an irregular rhythm. It is a normal beat followed quickly by a premature, weak ectopic beat and have a compensatory pause. This is a classic sign of digoxin toxicity or underlying arrhythmias. So how do we actually measure this at the bedside? Grab your blood pressure cuff and follow the steps carefully. First, inflate the cuff well above the patient's systolic blood pressure. Then deflate the cuff very slowly, about 2 mm mercury per heartbeat. Tell the patient to breathe normally. Do not ask them to take deep breaths as it will mess up with your readings. Listen closely. At a certain high pressure, you will start to hear Korotkov sounds, but only during expiration. They disappear when the patient breathes in. Note this exact pressure reading. Let's say it's 130 mm mercury. Continue deflating the cuff very slowly until you hear Korotkov sounds continuously throughout both inspiration and expiration. Note this second pressure reading, let's say 115 mm mercury. So subtract the second number from the first. First we got 130, then we got 115. So the difference comes out 15 mm mercury. Since 15 mm mercury is greater than 10 mm mercury, the patient has a positive pulsus paradoxus. Practice this on the wards. It is an invaluable bedside skill that saves lives in the ER. Now, let's look at a classic PG level clinical trap. We just learned that cardiac tamponade causes pulsus paradoxus, but are there clinical situations where a patient has true cardiac tamponade but pulsus paradoxus is completely absent? To answer your question, yes, and missing this can be catastrophic. This occurs when there is a pre-existing condition that either prevents the right ventricle from expanding or allows the left ventricle to decompress. In aortic regurgitation, the left ventricle is constantly being filled backward from the aorta, keeping its pressure so high that the septum cannot easily bulge into it. In atrial septal defect, the pressure drops are equalized across both sides because of the shunt. Similarly, in isolated left ventricular failure, the left-sided pressures are already profoundly elevated. Again, in concomitant right ventricular hypertrophy, the thick, stiff right ventricular wall resists the septal shift. So remember this, the absence of pulsus paradoxus does not rule out cardiac tamponade if these comorbidities are present. Now let's flip the coin over. Can a patient have pulsus paradoxus without having cardiac tamponade? The answer is absolutely yes. This happens when there are massive swings in intrathoracic pressure during respiration. The most common culprits are severe acute asthma and COPD. During an asthma attack, the patient is struggling violently to breathe out against obstructed airways, creating massive negative pressure swings in the chest. This pulls a huge amount of blood into the right side of the heart, causing the exact same septal shift we discussed earlier. Other causes include hypovolemic shock, where low blood volume amplifies pressure changes, pulmonary embolism, and bilateral pleural effusion. So always look at the respiratory rate and effort of the patient before jumping to a cardiac conclusion. Again, if there is a paradoxus, there is also a reversed pulsus paradoxus. This is defined as a rise in systolic blood pressure during inspiration or a fall during expiration. It is the exact opposite of what we talked about. So when do we see this? You will encounter this primarily in two settings. Firstly, hypertrophic obstructive cardiomyopathy, where during inspiration, the increased venous return actually helps widen the left ventricular outflow tract slightly, reducing obstruction and raising systolic output. We also see this in patients on positive pressure mechanical ventilation. When a machine pushes air into a patient's lungs, it increases the intrathoracic pressure during inspiration, squeezing blood out of the pulmonary capillaries straight into the left ventricle, which actually boosts up the systolic pressure. So keep an eye on the arterial line waveforms in the ICU. You will see this mechanical ventilation effect clearly. As part of a comprehensive cardiovascular exam, you cannot stop at the radial artery. You must check all the major peripheral pulses. Firstly, you have the temporal pulse, feel it on the temple, then the carotid pulse on the side of the neck just below the jaw angle, the apical pulse on the fifth intercostal space in the mid-clavicular line. Then you have the brachial pulse on the medial aspect of the upper arm. Then the radial pulse, which is probably the most commonly checked pulse, found on the thumb side of the wrist. Then you have the femoral pulse in the groin below the inguinal ligament. The popliteal pulse is hidden behind the knee in the popliteal fossa. Then the posterior tibial pulse, which is found behind the medial malleolus, and the dorsalis pedis on the dorsum of the foot. Now let's review the locations of the peripheral pulses for the upper limb. Firstly, you have the carotid pulse, which is located in the neck, medial to the anterior border of the sternocleidomastoid and lateral to the thyroid cartilage. A crucial safety tip: never palpate both the carotids at the same time. You may restrict blood flow to the brain or trigger a reflex bradycardia via the carotid sinus, causing the patient to faint. So now we have the brachial pulse, which is present medial to the biceps tendon in the antecubital fossa. This is where you place your stethoscope when measuring blood pressure. So how do we examine for the brachial pulse? Firstly, support the patient's forearm comfortably. Keep the arm abducted, elbow slightly flexed, and the forearm externally rotated. Palpate the brachial artery just medial to the biceps tendon at the antecubital fossa. Repeat the same technique on the opposite limb. Another two peripheral pulses in the upper limb, the axillary pulse and the subclavian pulse. The axillary pulse is palpated deep in the apex of the axilla against the humerus bone, whereas the subclavian pulse is felt deep in the supraclavicular fossa, pushing downwards against the first rib. Now for examination of the pulsations in the abdominal aorta, which is a key component of the abdominal examination. Firstly, apply firm pressure with flattened fingers over the epigastrium towards the vertebral column. Ensure the abdominal muscles remain fully relaxed. Flexing the hips and supporting the head can improve relaxation. Keep in mind, in obesity or marked abdominal musculature, aortic pulsations may be difficult to appreciate. So here is how you examine for the abdominal aorta pulsations. Now moving on to the lower limbs, assessing these pulses is vital for detecting peripheral artery disease, especially in diabetic patients. So firstly, the femoral pulse. Position the patient supine with the lower limbs relaxed. Use the pads of the index, middle and the ring fingers. Palpate just below the inguinal ligament, midway between the ASIS and the pubic tubercle. Assess the pulse for rate, rhythm, volume and compare both sides for symmetry. The hardest one to find is most probably the popliteal pulse. For this, flex the patient's knee slightly to relax the popliteal fascia. Place both of your hands around the knee and press your fingertips deep into the midline of the popliteal fossa against the posterior aspect of the tibia. Next, we have the posterior tibial pulse examination, which is an important assessment of the peripheral perfusion. First, allow the foot to remain relaxed and adequately supported. Then palpate just posterior to the medial malleolus. Identify the space between the medial malleolus and the Achilles tendon. Use a stable grasp and assess the pulse carefully. And lastly, we have the dorsalis pedis pulse, which is located on the dorsum of the foot, just lateral to the extensor hallucis longus tendon. Note that this pulse is congenitally absent in about 10% of healthy individuals, so always cross-check it with the posterior tibial pulse. So now let's move on to the peripheral comparisons. To check for a radiofemoral delay, you must palpate the patient's radial pulse with one hand and their femoral pulse in the groin with the other hand simultaneously. As we learned earlier, the pressure wave reaches the femoral artery just a tiny fraction of a second before the radial artery. So normally they should feel almost perfectly synchronized. If the femoral pulse feels distinctly delayed and weaker than the radial pulse, you have a positive radiofemoral delay. So what is the diagnosis until proven otherwise? The answer is coarctation of aorta. It is a congenital narrowing of the aorta right after the branching of the left subclavian artery. The blood traveling to the arms goes through unobstructed pathways, that is a strong radial pulse, but the blood going to the lower limbs has to squeeze through a tiny bottleneck, so we get a delayed weak femoral pulse. Other causes include severe atherosclerosis of the aorta or an aortic dissection blocking the lower vessels. What if the delay or the difference in volume is between the left wrist and the right wrist? That is a radioradial delay. To check this, pull both of the patient's wrists close together in front of them and palpate both radial pulses at the exact same time. If one side is weaker or delayed, it means there is an anatomical obstruction affecting only one arm's arterial supply. Your differential diagnosis should include, firstly, the cervical rib, which is an extra rib compressing the subclavian artery on one side. Next, aortic arch aneurysm or aortic dissection overlapping the origin of one of the subclavian arteries. Then you can also have trichiasoarteritis, which is an inflammatory disease that destroys large arteries, often completely wiping out pulses in one arm, which is why it's famously called the pulseless disease. It can also be peripheral arterial disease, which is localized atherosclerosis in one arm. The final item on our pulse checklist is the condition of the vessel wall. In a healthy young individual, when you completely compress the artery to stop the pulse wave, the vessel wall itself becomes undetectable. It feels soft and blends right into the surrounding tissue. To assess this, use your proximal finger to completely occlude the radial artery so no blood flows through. Then, use your middle and distal fingers to roll the empty vessel against the underlying radius bone. If the vessel wall still feels hard, rigid, tortuous, or feels like a hard piece of cord or rubber tubing, even when empty, it is abnormal. This is a direct physical sign of monkeyverse arteriosclerosis or medial calcific sclerosis or even severe atheroma formation. It tells you that the patient's macrovascular highway has lost its elasticity and is heavily calcified. We have covered an immense amount of clinical knowledge today. Let's consolidate everything into a rapid-fire summary checklist. Whenever you document a pulse, your brain must automatically answer these 7 core questions. First, the rate. Is it normal, tachycardic, or bradycardic? Did you correlate it with temperature? Second, the rhythm. Is it regular, regularly irregular, or completely chaotic like atrial fibrillation? Third, the volume of the pulse. Is it high and bounding or low and thready? What is the pulse pressure telling you? Fourth, the character. Are you dealing with a collapsing pulse, a twice beating disvariance, or an alternating pulse? Fifth, the delays. Have you ruled out radioradial and radiofemoral delay? Sixth, the peripheral pulses. Are they symmetric and equal from head to toe? Seventh, the vessel wall. Is it soft and healthy or rigid and calcified? Master this checklist and you will never miss a cardiovascular clue at the bedside. For those who want to dig deeper into physics of pulse wave propagation or read the classic case studies on waveforms, all the concepts discussed today are grounded in our gold standard clinical textbooks, Hutchinson's Clinical Methods, MacLeod's Clinical Examination, and Braunwald's Heart Disease. I highly encourage you to open these chapters tonight while today's practical demonstrations are still fresh in your minds. As future physicians, remember this. Medical technology will continue to advance, but nothing will ever replace the clinical accuracy and human connection of a well-performed physical exam. The next time you take a patient's wrist, don't just count the numbers. Read the story their heart is telling you. Thank you for your attention and work hard on the wards.